So I think already about bifurcation, what about the tips and tricks? Because all the time, in every conference, somebody is telling the tips and tricks, but I don't know that what actually the tips and tricks, because every interventionist has got their own way to do the any procedure actually, and some uniform tips are there, and which already has been discussed. So it will be a boring one for you and for everybody here. But you know that the bifurcation is a two-way street, and talking about bifurcation PCI is not a hypothetical issue. Only subset of the lesions for PCI, other than CTO, calcification, other ones, but bifurcation has become very much scientific nowadays in the world. And you have to be a physicist, you have to be a mathematician also, because everything is counted there. And thanks to EVC actually, because that is the only platform since 2004 has made it possible. So, tips and tricks, this is still not an easy question. And sometimes it's very much hard to predict in a real world cases, because whatever you are telling, theoretically, it's not possible all the time. Sometimes difficult to plan. 20% of the lesion subset you are facing this one every day. So in real world, it may be left main or non-left main. If it's a left main, that's a different animal. You have to think in a different way. If it is a non-left main, the procedural decisions will be very much diversified. You can go for any way, this way, that way, or something with not without compromising the patient's status in the table. So that is possible. These are all the real world left main and non-left main cases I can tell. If you go from the basics, while dealing the bifurcation, actually dealing with three anatomical segments, and starting from the very beginning, that like three Caspers there, but here only Casper is very much important, is a side branch. All bifurcation techniques and talks revolves with this one. And that's why the question is whether it is relevant or not relevant. And that's the question. Diameter, whether it is significant or not, it has got some still, there is no uniform idea. Because like in Kobe's before, more than 2.3 millimeter if it is, then it is relevant. In definition, more than 2.5 is if it is the diameter, then you can take it as a relevant side branch. Lesion length from SB, that is also very much important, more than 5 or more than 10. In definition, more than, if it's not more than 10, it's not that much complex. And supplying more than 10% of the myocardium, theoretically 73 millimeter length, long side branch means it's supplying more than 10% of the myocardium. We can take it into account. So that is true. Now comes to the true and non-true nomenclature, which already have seen, but obviously anatomic and angiographic. But at the same time, if you go for imaging, then you can tell properly that whether it is a true or non-true bifurcation much more precisely, and physiology testing will tell you that whether you have really a significant side branch stenosis or not. So sometimes angiography is not the optimal result, but Medina has used the angiographic criteria, and if you, the real and the fake bifurcation lesions, whether it is a true. So I'm thanking Alfonso Medina for that one, because it is widely now circulated in the whole world. And what is true, the 7 sets are there, 111, 11, 101, 011, and 7. These 7 sets, these 4 are non-true. That is 110, 1010, 001, and 100. But the true ones are these 3. That means 111, 011, and 101. But this 101 is not the truest true, because in the complex bifurcation lesson using in the ABC main or the DK crash 5, 101 is not, they didn't include in the true bifurcation lesion. So this one is a gray zone here for the true bifurcation. Complex true, already you have been told that you have to follow the definition criteria, that is the best way. If the treatment strategy, if we come in a nutshell, the maths, what already you know that this is a complex scenario, you have to memorize this one, and inverted techniques also you have to remember, because you have to mention it while telling a bifurcation technique. You don't know, if you don't know the inverted one which one and the standard one which one, then it's a problem. So you have to know the inverted techniques. But consensus is there now, And difference of opinion is there too, that which philosophy you will apply. Even in the 16th EBC, they have told these things. But in a nutshell, two strategies, which already has been told, the stepwise layered provisional strategy, usually single strategy, or bailout two strategy. That is included in the provisional philosophy. And also upfront or systematic two-stent strategy like tap, crash, and culotte. I didn't include the other stenting techniques there. What is provisional philosophy in details? This is very much important to remember all the time, that stenting the main branch first and then go for a pot and done. Up to that one is the provisional philosophy or provisional single strategy is ended. But it may go for a KBI if you go for the EBC main, then they have done the kissing balloon inflation for the side branch and the distal main branch, and then it is finished, you can stop there. But it may end up with a bailout two-stent strategy. So up to these things are the provisional philosophy. And if you go for this philosophy is still tells that this is the better one, because this meta-analysis of including the two RCTs and the 10 observational studies, they're telling, yeah, TLR is less. But that is only in the observational studies, not in the RCTs. So still there is a controversy there whether provisional is all the time better. No, this is not. So in real world, complex two bifurcation lesions have some alternative verdict, which this EBC main and decay crash and the quarrel between these two trials from two geography of the whole world is just creating this sort of controversies, that whether you will go for the upfront two-stent strategy or that will be better or not, or the provisional will be the better or not. So this thing is there. And this hard talk, because the subset in these two landmark trials is totally different. Like syntax score is low in EBC main, syntax score is high in decay crash, and also the lesion lengths, SB lesion lengths are higher in decay crash. So for that subset, obviously decay crash 5 trial is true, you have to go for a upfront two-stent strategy rather than thinking of a provisional philosophy as is told by the guidelines or the European Bifurcation Club. And that is also true that if you go for a bailout in provisional philosophy, in definition trial, they have shown after 3 years, when you have taken the provisional philosophy, and that is, it has ended up with a bailout two-stent strategy, in that case TLR is higher. So you have to go back and you have to rethink that whether upfront strategy from before was better, would be better. So you have to plan very well and think very well which way you will go. So there easy grays also is there. And this debate and confusions and also the choice of the two-stent strategy is still a bit geographical, because this part of the planet loves decay crash, that part of the planet loves culotte or tap, not the decay crash. Only 3 or 5% they are doing the decay crash. So that is why. So whatever, we have to choose according to our expertise that which technique we will take for two-stent strategy. Now I am coming to the few minor details of the bifurcations, like understanding the distal reference diameter. I am telling again and again because this is very much important for the upfront two-stent strategy or for any bifurcation PCI, because you have to put the stand according to the distal reference diameter, not by the proximal MB or proximal vessel diameter. So that is very much important, and wiring and rewiring is very much, it's an art. That's the best, most important thing for a bifurcation PCI. Jailing the wire and wire wrapping, that is also very much important. Pot and KBI with a perfect fashion should be done, and choosing the stand platform is also very much important. So we have to know the Finner's formula, that 2/3 of the D2 and D3. That is, you have to keep all the time in your mind. Angulation is very much important because acute angle you have to go for it. And wiring both SB and MB, here all the time, it's better to go for a pullback technique. If you can't, then take an additional third wire. And obviously, for rewiring, distal structural wiring, you have to remember, except decay crash, where the proximal wiring is important, that is the mantra. And jailed wire. don't pull the wire, so far it is the consensus, don't pull the wire before pot. After pot, pull the jailed wire, because that helps you a lot. And also modified gel balloon technique is also very much popular in this part, but not in that part of the world. And pot already has been told that you have to put the balloon just proximal to the carina, and that is the thing to make a perfect pot. And that perfect pot is very much important because it will help a lot for everything. For kissing balloons, it's a legendary one you have to keep. The balloon size you have to choose according to the distal reference diameter of the toe side branch, not the proximal branch, never ever. And also 12 atmosphere for the modified kissing balloon inflation, not more than 12 atmosphere for the both balloons. That is very much important. And sometimes after case you have to go for a pot, mandatory pot, otherwise the bottleneck deformity may happen, which you should not keep in that way. And stand platform you have to choose, because you need the stands like 1.5 to 2 millimeter more expandable, because you don't know how much you have to inflate that one, even after IVUS. And role of physiology and role of IVUS is very much important. They're still a class 2A, but the future forward is telling angiography and FFR there is no difference, but FAME 2 is telling that obviously FFR has got a role to decrease the stent material. And also for IVUS is a class 2A, but it is going towards class 1 according to the availability in the whole world. So that is all these things, and these steps I'm skipping because already it has been told. Only thing, the last point is here, that the crush. Not only the decay crush, you have got a nano crush, you have got a mini crush, you have these possibilities are there. So you have to keep in your mind all the procedural steps of these 3 types of crush now, because that will help you a lot. Not only you will depend on decay crush, you have nano crush techniques, you have mini crush techniques, and you have to know these differences of these steps, and also the positivity of any of these techniques, which one will be best according to the anatomy of that case. So this is decay and this is decay nano crush. Finally, I am telling possible future direction in true bifurcation lesions, handling for better provisional philosophy. What is the future direction? Leave nothing behind philosophy, or leave less, and to overcome the odds of POVA in side branch. That is the only thing. I am talking about the drug-coated balloon in bifurcation PCI. Currently, 2 DCB strategies, 2 drug-coated balloon strategies, DCB in the side branch and this in the main branch, or DCB, somebody like 30 to 32 patients trials are there, observational studies are there, they have put both DCB in both SB and MB. And I'm telling you that Antonio Colombo, when starts something, he usually end up to incorporate in the guidelines. Like Colombo is now doing everything DCB. He started hating stent materials. So DCB is the choice, but not all the time. So DCB in both SB and MB, pot, side pot. You can go for a pot, side drug-coated balloon, and then repot. So provisional philosophy is finished. Like that case in the last case. You can go for that one. You will go for a proximal and distal MB stenting, followed by a pot, followed by a DCB, side branch, dilatation, and then final pot. Then it's clear, and it will be better. Sometimes EBC has incorporated the role of DCBs for the 001 lesions, like in the side branch severe osteal lesions, you can end up with DCB only. So it's possible also. So that is while I wrap up in that, I want to wrap up in that way. In real world, tips and tricks of any PCI procedure need to be realized in one's own way also at the same time. Pot, rewiring, KBI at the base of any bifurcation PCI. There are some specific rules out there. You have to maintain those rules. Operators' expertise and preferences of techniques are very much important for 2 stent techniques, as seen, you have seen also in EBC main and decay crush 5, that how much it is different. For complex bifurcation lesions, ad hoc PCI is rather to be postponed. You can go for a planned, front, 2-stent strategy next day so that you can keep your brain cool. And role of drug-coated balloon, we have to rethink, and of course we need more data for that one. Thank you very much for your patience hearing.
Thank you very much for your nice presentation. With this, we conclude our session, but before that, may we request all panelists, chairperson to come on the dais and have a grace-giving ceremony to the presenter.